Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 579 of our pharmacotherapy series, which majors in geriatric drug use. The first case reads, PCW, a 71-year-old retired schoolteacher, has been suffering from osteoarthritis of his hands for 5 years. He is an active older adult who enjoys volunteer work at the local hospital. He presents to the geriatric clinic with increased arthritis pain, which is uncontrolled by his current pain medication. He also complains of increased heartburn and gastric reflux symptoms. His past medical history is significant for diabetes, hypertension, hypercholesterolemia, and GERD. PCW's current medications include G-lipotide 10 mg daily, verapamil sustained-release 240 mg daily, atorvastatin 10 mg daily, famotidine 20 mg twice daily, docusate sodium 100 mg twice daily, and ibuprofen 200 mg 4 times a day as needed. My first question to you reads, what modifications can be made to his drug regimen to better control his arthritis pain and minimize side effects from his pain medication? Acetaminophen is the drug of choice for mild to moderate arthritis pain. Though pain control may be inferior to non-steroidal anti-inflammatory drugs, its reduced gastrointestinal and renal toxicity provides an advantage in older patients who may be more susceptible to the adverse effects of non-steroidal anti-inflammatory drugs. Doses greater than 3,000 mg per day should be avoided in the elderly, and more conservative dosing utilized for those with a history of alcohol abuse or hepatic impairment. If PCW has not tried acetaminophen in the past for his arthritis pain, acetaminophen 1,000 mg 3 times a day should be initiated. Older patients with osteoarthritis pain often find relief from non-steroidal anti-inflammatory drugs, which should be used with caution because of their potential GI complications, renal toxicity, and cardiovascular risks. Though not as common as GI toxicity, advanced age is a major risk factor for non-steroidal anti-inflammatory drug-associated renal toxicity, such as sodium and water retention, as well as risk for hypertension. Thus, ibuprofen may be contributing to PCW's increased GERD symptoms and to his hypertension. Non-acetylated salicylates, such as salsartate, can be used if acetaminophen does not provide adequate pain relief. Compared with non-steroidal anti-inflammatory drugs, non-acetylated salicylates have less renal and GI toxicity, but cardiovascular risks are unknown. The currently available selective COX-2 inhibitor celecoxib is less likely to cause GI complications than non-selective agents. However, the risk of adverse renal and cardiovascular events persists. A COX-2 inhibitor or the addition of a more potent gastroprotective agent such as a proton pump inhibitor to ibuprofen is the option for PCW, who may experience reduced GI symptoms with equally effective pain relief. The topical analgesics often require multiple daily applications, assessment of skin integrity, and application technique. The use of glucosamine and chondroitin has been shown to decrease osteoarthritis pain and delay progression of the disease in some studies. However, their place in therapy is controversial. Glucosamine may increase insulin resistance in diabetic patients, and PCW should be counseled to monitor his blood glucose more closely if initiating this agent. PCW reveals that he has tried acetaminophen without much relief of his pain. He is prescribed celecoxib and tries it for several months, but his pain continues and he is still experiencing GI distress. My next question to you reads: what other pain medication options does PCW have? For moderate to severe chronic pain caused by osteoarthritis, a low-dose opiate may provide relief from pain with minimal adverse drug effect. Of particular concern in elderly patients are the risks of falls, delirium, and constipation with opioid medication use. Codeine and tramadol are weak opioids that have ceiling effects, generally do not provide adequate analgesia, and may carry dangerous side effects in the elderly. Meperidine should also be avoided in older adults because of its high potential for CNS side effects, especially in those with reduced renal function. PCW is a candidate for opioid therapy. He should be started on the lowest dose of a short-acting formulation on a scheduled regimen and counseled on the adverse drug reactions. Constipation may be a particular problem because he is also taking verapamil, which can also cause significant constipation. The elderly are also at increased risk for constipation as a result of age-related reduced bowel motility. To prevent opioid-associated constipation in PCW, prophylactic laxatives and stool softeners should be started at the initiation of opioid therapy. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 580.